بسم الله الرحمن الرحيم. Thank you for joining me today, and we will start our second talk. This talk will be application of what we have already learned about the art of history taking in the previous lecture. So we will try to follow the same scheme that we have already decided during the first talk. I mean, we will each case we will take the stem or the scenario of the case, and then we will start to discuss what could be the positive finding in the history of present illness, what could be the positive finding during the systematic review, what could be the positive finding in the past medical history and the family history, and also in all types of history. So we will try to find the positive findings in every and each type of the history, part of the history, and at the same time also to set by the end of the discussion a sensible differential diagnosis. So during this talk, we will try to take an example of cases from the cardiovascular system, cases from the GIT cases, from the GIT system, and cases from the endocrine system. This is a disclosure about the conflict of interest. The author do not have any conflict of interest to declare, whether financial or non-financial. We will start to discuss cases from the cardiovascular and chest systems, and we will see how to approach them. I prefer always to start with simple cases that we face in our everyday practice. So I will start by a case of hypertension. This is a scenario. You are a registrar in the medical department, so this is your rule. Ms. Sarah Nauman, this is your patient, is a 24-year-old lady, recently found to be hypertensive following attack of headache and blurring of vision. Please talk to her and answer her concern. If you would like this session to be an interactive session, I think it will be more useful and beneficial to everyone. So do you have any idea about how to proceed in this case? This is a very simple case. This is a case of hypertension in young. So I think we should search for something in this case. Before discussing the case with the patient, you can even set a sensible differential diagnosis before starting the talk, and at the same time, this differential diagnosis might change during the discussion with the patient. You may, from his symptoms, from any positive data, you will get another differential diagnosis, or maybe you will exclude one of the differential diagnoses that you already put before start talking to the patient. So as I told you, we will be very classic, and we will follow the scheme that I have give you in the first session. We will start by the history of present illness. In the history of present illness in hypertension case, we will start to ask about symptoms of uncontrolled hypertension, like headache, visual disturbance, chest pain, palpitation, and dyspnea. We all know that most of the cases of hypertension, they have no symptoms, but sometimes if the blood pressure is very high, the patients might be symptomatic, like as I told you, headache and visual disturbance and so on. So symptoms of end organ damage, like neurological symptoms, visual and neurological, and macrovascular complications and microvascular complications. In the macrovascular complications, there might be CNS complications and the peripheral vascular disease, like if the patient is having cold extremities and claudications and so on, and he might be also having ischemic heart disease. Microvascular, retinal, and renal. The renal can be expressed by the patient as nausea, lethargy, and ankle swelling. So you have to ask about if those symptoms are present or not. This is in the history of present illness after analysis of the complaint of the patient and start to ask about the system disordered. Then the systems related, you will be asking about the endocrine system, renal system, and psychiatric system, because it's nonsense if you have, for example, a case of hypertension, and you start asking about the dermatological systems or dermatological symptoms and signs. It makes nonsense. But as I told you, we will start to ask about the complications, the red flags, the analysis of the complaint, and the system related, disordered. And then we will start by the systems related. In the systems related, if a young patient, definitely the endocrine causes of hypertension and the renal causes of hypertension are having the priority in such a case. So you have to start by asking about the endocrine symptoms of thyrotoxicosis, Cushing syndrome, acromegaly, men type 2, and Conn's disease, weakness, lethargy, muscle cramps, pheochromocytoma, like palpitation, sweating, and weight loss. And you will ask about the renal symptoms, like history of recurrent UTI, renal stones, and also, as I told you, buffness of the face, frothy urine, decrease in the urine volume, and so on. The psychiatric symptoms also are very important in such case because the cause might be only psychiatric. So I have to ask about the anxiety and white coat hypertension. Now we finish the history of present illness, which we included analysis of the complaint and also the analysis of the system disordered and analysis of the systems related. So now we will start by asking him about the past history. And we give in the past history a monomer which is called PAT-MIC. Okay, so in the past history, you may find in the case of hypertension, peripheral vascular disease, or a past history of dyslipidemia or other complications of hypertension. Also in the family history, you might have a history of hypertension or a history of multiple endocrine neoplasia, dyslipidemia, or diabetes. They are all risk factors for developing hypertension. Sometimes the case will come that they told the surrogate or they told the patient, if he asks you about the family history, tell him that you are adopted. Or the same word will come in the step of the exam case. So if he said adopted, means that he don't want you to confirm that he has a family history to make your differential diagnosis more wide. Please mute yourself. And also, when you ask about drugs history, you have to ask about the non-steroidal anti-inflammatory drugs, the nasal decongestant, the oral contraceptive pills, the corticosteroids, because all these drugs can increase the blood pressure. You can ask also about anabolic steroids, illicit drugs, cyclosporin, and complications of antihypertensive drugs. All those drugs are risk factor for developing hypertension. The social history also, this patient might be smoking and this is a risk factor. He is working in a very stressful occupation. He is alcohol drinker or alcohol abuser, and he has some marital problems which causes his high blood pressure. So this case, for example, was an exam case, and the differential diagnosis here was maybe pheochromocytoma and men type 2, because she has a family history of operation in the neck for thyroid medullary carcinoma. So there was a suggestion or suspect of this patient that he might be having a men type 2. As I told you, all other endocrine causes should be excluded. Also, in the investigation, you will tell the examiner that you will do blood works to exclude all the endocrine causes, and also you will do renal artery duplex to exclude renal artery stenosis, and also do kidney function test. And this patient also was having another risk factor because she was taking illicit drugs and she was on oral contraceptive pills. Then you will be asked to mention how you will be managing this patient, and I will leave this for the books and for the theoretical description. دي كانت حالة هايبرتنشن عادية خالص، احنا بنشوفها كل يوم وممكن تيجي في الامتحان. ممكن يجي في الامتحان يعني أكتر من diagnosis. ممكن يجي differential diagnosis زي هنا قلنا الحالة ديت عندها family history ففي possibility of men type 2. بس كمان في الهيستوري لما خدنا منها هيستوري كانت البيشنت is on illicit drugs. She was addict to cocaine and at the same time she was taking oral contraceptive pills. فكده حطينا differential diagnosis. The correct answer or the correct diagnosis was men type 2. وبالتالي احنا ال true diagnosis بتاعنا او ال correct diagnosis is one of our differential diagnosis. كده يبقى احنا فعلا the case is completed and we got the mark. طيب في اي حد عايز عنده اي اسئله او استفسارات مثلا عن الحاله دي او الطريقه اللي احنا ماشيين بيها؟ اوكي طيب دي حاله من حالات الجنرال history taking may be related to some extent to the cardiovascular system، لكن ان شاء الله باذن الله هيكون عندنا سيشن عشان نتكلم فيها على الفيج كيسز والجنرال كيسز. انا بس حبيت ابدا بيها لانها جنرال related to the general system and also it's also related to the cardiovascular system. هنبدا باول حالات اللي هي حالات الchest cases. وعندنا هنا في حالات الchest cases اللي هو البريثلسنس means short of breath. طبعا البريثلسنس ده ممكن يجي مع حاجات كتيره، فهنبدا باول حاجه اللي هو short of breath and worsening asthma. الكيس كانت you are a registrar in the chest department and the scenario speak to Mr. حامد خليفه 35 years old who recently suffered worsening asthma. طيب ده كده خلاص كده خلص السيناريو بتاعنا. اول حاجه انت you identified your role, you are a registrar in the chest department. So first you have to greet the patient. Good morning, good morning Mr. Hamid, good morning. Now when you mention his name and he answer you or reply to you, this means that he's confirming his name. So good morning. Yes, good morning doctor. I am Dr. Sharif, one of the registrars in the chest compartment, chest department. Okay, doctor. Are you Mr. Hamid Khalifa, 35 years old? Yes, doctor. I think we are here today to talk about your current health situation. Are you ready to talk about it? Yes, doctor, I'm ready. So your GP has sent to me a letter informing you that you have started to have suffering of worsening of your bronchial asthma. Am I right? Then he will start to talk and you start the conversation or start taking the history. So an advice here, always challenge the diagnosis. This is not only in the exam, but also in your daily practice. Because if two doctors label a patient with a diagnosis, it will be very difficult to change this diagnosis. يعني لو انت شغال دلوقتي النهارده في مستشفى وجالك مريض راح عند 2 من الاطباء المشهورين او الاطباء يعني اللي هم عندهم شهادات كويسه، وجي قال لك ان هم الاثنين شخصوا لي تشخيص واحد، دي اعتقد هيبقى صعب جدا انه يتغير التشخيص بتاعك. وبالتالي اذا جالك اي مريض من من طبيب زميل ليك وهو متشخص تشخيص معين، try to challenge this diagnosis. Try to think if this diagnosis is true or not, because if you give him the same diagnosis, you will be labeling the patient, and if the patient is labeled, then it will be very difficult to remove this diagnosis. This is an advice, maybe not related to the exam, but it's related to your daily practice. This means that don't take it as for granted asthma because it's just mentioned in the scenario. So the discussion with the patient will reveal if this is really a worsening asthma or not. So the data in the scenario is always true, but the diagnosis most of the times not. This is especially in the exam cases. طيب نبدأ ازاي مع الحالة دي؟ breathlessness with worsening asthma. أول حاجة you have to confirm that this patient is having asthma. ايه هي الحاجات اللي انت تسأل عليها العيان عشان تعرف if this patient is a true asthma patient or not. أول حاجة تسأل على diurnal variation. Okay, is it worsening by night or not, or is it changing from day to night, your asthma? The effect of inhalants, is it improving with inhalants or not? And the peak flow reading. The peak flow meter is usually with the patients, and usually they are checking their peak flow reading, and they are always taught by the family doctors how to read the peak flow meter and how to follow the peak flow meter readings, and also to report once they have any major change in the reading. So you have to ask him about his peak flow reading. Does your peak flow reading is worsening or not, and when it is worsening? So if after you ask him the previous 3 questions, if he answer yes about the previous 3 questions, or he give you an answer that indicates that his asthma is worsening, now you are definitely talking about a case of worsening bronchial asthma. So what are the cases or what are the causes of worsening bronchial asthma? Remember, this is a very important case, not only in the exam, it is a case present in the real life. You have to ask him about trigger factors like pollens, dust and mites, cats, dander. Maybe they have a new pet. Maybe someone gave him like a cat as a gift in his birthday and so on. The problem of the cold air, this is because of the winter, the patient is suffering from worsening asthma. He's smoking, or maybe exercise-induced asthma. He is using drugs like aspirin, or sometimes occupational. والoccupational دولت في patients اللي هم they are using isocyanate or platinum. You have to ask him about also a history of allergic rhinitis and atopic eczema, and history of drug allergy and so on. Again, this might be very simple cause for this worsening asthma. Maybe this patient is not adopting a proper technique of inhaler use, or maybe he's not compliant with his inhalers, or maybe he is embarrassed of using the inhaler. He's working all the day and he's embarrassed to bring his inhaler out and start using it in front of his fellows or friends or colleagues in the work. Okay, so this is if the asthma is confirmed. As you can see here, also the patient can be suffering from GERD, gastroesophageal reflux disease, causing worsening of the asthma because of the micro showering of the gastric acid into the lung. And also these patients have allergic rhinitis with post-nasal discharge. Rare cases might be like allergic pulmonary aspergillus, carcinoid, Churg-Strauss disease, and also all the cases of autoimmune يعني microvascular disease. So you will find all this differential diagnosis in the book. So try to first make sure that this is a worsening asthma, and then take the history of a worsening asthma as I told you. So if the asthma is not confirmed, or this is not a case of worsening asthma, you have to think about other differential diagnoses of shortness of breath and worsening asthma, or as you will see, a dry cough, like in pulmonary embolism or pulmonary fibrosis. Nitrofurantoin can cause pulmonary fibrosis if used for a long time. Amiodarone also can cause pulmonary fibrosis. And as I told you also, amiodarone is one of the drugs that you have to take a verbal consent from the patient. Methotrexate is a chemotherapy and also can cause pulmonary fibrosis. Vasculitis, as I told you, small vessel vasculitis like microscopic polyangiitis, vaginal granulomatosis, SLE, anti-GPM. In anti-GPM, you will find the patient is young, smoker, and has a blood urine. Drugs can cause dry cough and shortness of breath also, or worsening asthma is like AC inhibitors from the first week until the 6 months after start of the treatment can cause dry cough and anaphylaxis with wheezy chest. Non-steroidal anti-inflammatory drugs can cause also worsening of the asthma or wheezy chest, and also aspirin can cause also wheezy chest with a dry cough. Beta blockers can cause bronchoconstriction and exacerbation of already asthmatic patient. And social history, as I told you, the smoking and the job. So the answer of this case was that this gentleman most likely have worsening asthma related to his job, because he was feeling free during the off days, and at the same time another risk factor could be in non-compliance with his medications. And then you will be asked what you will do for this patient, what investigations you will do, and how you will manage this patient. Another chest case is breathlessness and dry cough. So before proceeding, do you have any concerns or questions? Okay, so the second case in the chest system or chest disease is very important also, is breathlessness and dry cough. You are a registrar in the medical department. Mrs. Dalia Sadiq, 45-year-old lady, complained of shortness of breath of 2 weeks duration accompanied by dry cough. She has no wheezes but did not respond to usual lines of treatment. Please talk to her and answer her concerns. So this lady was having interstitial lung disease from prolonged intake of nitrofurantoin. Actually, this case was a case of a lady who has a history of recurrent UTI, and she started taking chemoprophylaxis a long time ago. She is taking 1 to 2 tablets of nitrofurantoin per day as a chemoprophylaxis to prevent recurrence of the infection. So she has some renal symptoms, and there might be some renal failure with pulmonary congestion secondary to recurrent UTI, or she might be having a nitrofurantoin-induced pulmonary fibrosis. She has also, from the history, another risk, which is post-nasal discharge, and she must be referred to the ENT to exclude a post-nasal drip related to the allergy. So you will put your first differential diagnosis, it will be ILD from prolonged intake of nitrofurantoin, because this can cause shortness of breath and dry cough. The second one is the post-nasal discharge, and that she must be referred to ENT. And then the third one will be renal failure secondary. Might be she might be at risk of renal failure secondary to recurrent UTI. This will give you a very sensible and reasonable differential diagnosis. We will take another case related also to the chest, which is very common also in the real life and also in the exam, the chest pain and shortness of breath. You are a registrar in the medical department. Mrs. Iman Salah is a 24-year-old lady presented to your clinic with shortness of breath and non-cardiac chest pain. Please talk to her and take a history. What is the differential diagnosis for shortness of breath and chest pain? If it is cardiac, it will be acute coronary syndrome, constrictive pericarditis, and valve lesion. And if it is chest, it will be pleurisy, pneumothorax, pleural effusion, pneumonia, and definitely pulmonary embolism. And pulmonary embolism is a very common in the daily practice, and also very commonly missed. Interstitial lung disease, you have to ask about collagen disease, especially scleroderma, and pulmonary hypertension, primary or secondary, and you have to ask about the history of HIV and appetite suppression drugs. Drugs also can cause shortness of breath and chest pain, and also the GERD. In PE scenario or pulmonary embolism scenario, and we will take a few slides about the pulmonary embolism. In the scenario of pulmonary embolism, he may state that this patient is having chest pain, especially pleuritic chest pain, or she is on oral contraceptive pills. You may have some clues during discussing the case with the patient or taking the history that she might be taking appetite suppressants, or she has a lower limb edema and she came from long-haul flight, or she's pregnant and long recumbency in bed, and so on, because of fracture of her leg and so fracture of her leg bone and so on. So you might have some clues while discussing the case with the patient or from the scenario. What is the differential diagnosis, or what are the causes of pulmonary embolism? We have familiar causes like thrombin C and S deficiency. I hope this is a useful revision for you. And antithrombin deficiency, homocystinuria, and factor V Leiden mutation. The acquired causes could be antiphospholipid syndrome. So you might be having a case of pulmonary embolism secondary to antiphospholipid syndrome. So while you are doing your systematic review, you will find that this patient is having symptoms of antiphospholipid syndrome. She has repeated abortions, she has migraine, she has and so on. And also she's associated with SLE, so it might be like a case of SLE. Yani she has also locomotor symptoms, so she might be a case of SLE with antiphospholipid syndrome and secondary pulmonary embolism or acquired pulmonary embolism. So you have to dig in the history to reach the proper and even at least sensible differential diagnosis. Behçet disease, paroxysmal nocturnal hemoglobinuria, cancer, and thrombophilia associated with polycythemia rubra vera, thrombocytosis, and myelofibrosis. From the history also, you can find that this patient is having anemia, which is a risk factor for PE, heart failure, nephrotic syndrome due to loss of protein C and S in the urine, and recent pregnancy, surgery, and admission to the hospital. Also, you may find that this patient is having vasculitis like microscopic polyangiitis or Wagner's granulomatosis, SLE, as I told you, or anti-glomerular basement membrane. Remember also in case of PE to remember always the Wells score, because if the patient is at high risk, you have to proceed for pulmonary angio or ventilation perfusion scan and so on, and also start anticoagulation. If the risk is low, so no need to do all this. What is the Wells score? Wells score consists of certain items that you give them a score. If the score is low, means from 0 to 1, this is a low risk. If it's from 2 to 6, it's a moderate risk. If it is from 7 to 12.5, this is a high risk. What are the items of the Wells score? Hemoptysis, plus yes or no, immobilization, active and recent cancer. Immobilization means that immobilization for 3 days or more during the last 3 months, and active and recent cancer, tachycardia, DVT, diagnosis of PE is most likely, and prior PE. So for PE, Wells score, there is very famous monomer, which is don't die, tell them immediately to calculate the score. You can use the first letter of each word to indicate one of the items of the Wells score. Don't, D stands for DVT, means that this patient is having now DVT. The second D stands for the previous DVT, which might be the previous DVT, or it's the most likely DVT, or previous PE. T stands for tachycardia. IMM stands for immobilization or recent operation. Calculate, is the C here stands for cough, and the score, the C here stands for cancer. So if you memorize this monomer, maybe you will not forget, or you will not miss any item of the Wells score. And usually, if it is a case related to PE, or one of the differential diagnoses is PE, you will be asked about this score. We will take a case from the cardiovascular system, and you will find a lot of examples in the book. So you are a registrar in the medical OPD. Mr. Saeed Ibrahim is a 26-year-old engineer complaining of palpitation. Please talk to him and manage his concern. So this is a case of palpitation or awareness of heartbeats. From the discussion of this case, or during history taking, this gentleman was found to have an extrasystoles, most likely related to stress and coffee. And the other differential diagnosis in his history was possible high thyroid function test, because he said he lost some weight and he has some fine tremors. And also he's working in a very stressful job. So as I told you here, the social history is very important. And also from the drug history, he was on antidepressants also. And this might cause, as you know, arrhythmia and torsade de pointe. Now we will move to the GIT system. There are a lot of cases and a lot of scenarios that you can have in the GIT, but I put here only few notes, and I started to emphasize on the most important points that you can face in your daily life, or you can also face in your exam. A patient with abdominal pain. You are a senior house officer in the medical department. This is your rule. And Mrs. Nadine Khalifa, this is your patient, is a 30-year-old lady presented with abdominal pain and joint pain. So this is a case of combined abdominal pain and joint pain. So, and the system disordered, you will analyze everything related to the abdomen and everything related to the joint. Then start by system review. Maybe in the system review, you will start by the skin, by the dermatologic system, and so on. And then you proceed for the cardiovascular system, for the chest system, and so on. So what is the differential diagnosis of undiagnosed abdominal pain? We mean here by undiagnosed abdominal pain if it's stated in the scenario that this patient was extensively investigated and no clear diagnosis was found, or you find that the diagnosis of the abdominal pain is outside the GIT. So you have to think about the DKA, the vasculitis, most likely polyarthritis nodosa, infections, enteritis and peritonitis in the GIT, or drugs like diadosine that can cause pancreatitis, and it's one of the drugs given with HIV, malignancy like lymphoma and Kaposi sarcoma, familial Mediterranean fever, Addison disease can cause also abdominal pain, and acute intermittent porphyria. This is very important differential diagnosis, not only for the exam, but also for everyday practice. So this scenario was a case of familial Mediterranean fever. And the other differential diagnosis was SLE, because she was young, and also she was having also some small joint pain and so on. And also this likely was the reactive arthritis. So as you can see here, we put a 3 differential diagnosis, but one of them is the most likely one, or almost the correct one. We will give a brief only about dyspepsia, which is very important also in daily practice and also in the exam. In case of dyspepsia, is most likely the diagnosis is very simple, but the case is always there to ask about the investigations and the differential diagnosis and so on. But if you have a patient with dyspepsia and you are going to ask him about his symptoms, first you have to start by the symptoms of the GIT, and the flag symptoms or the alarm symptoms here are very important to ask about, because they will make a big difference in your management. What are the alarm symptoms? For the case of dyspepsia, it has a monomer called alarms plus. A stands for anorexia and awake from sleep. L stands for loss of weight. A stands for affect quality of life. R stands for resisting symptoms. M stands for melena or hematemesis. S stands for swallowing difficulty or early satiety. If you have any one of those alarm symptoms plus jaundice, gastric ulcers, vomiting, and dysphagia, and so on. If you have any one of those symptoms, this you have to raise the alert, and also you have to raise the red flag and immediately intervene with the patient and refer him, do endoscopy, do an invasive procedure, and so on. So if you have this one of those symptoms like alarms plus or above, and the patient is above 55 years, you have to proceed for endoscopy. If there is no alarm symptoms and signs, you have to start with PPI for 4 weeks, and if it's not improving, you can do the H. pylori test. This is called treat and test. Treat and test technique. If you have a case of renal colic in the exam, don't forget the differential diagnosis, this important differential diagnosis, because it will not be a simple case of renal stool. So the case might be a gout or high parathyroid hormone, and this will lead you to ask about all the endocrine system and find that this patient might be having MIN type 1, sarcoidosis, a case of sarcoidosis. If you consider any chest symptoms or eye symptoms and joint symptoms and so on, and it might be a case of Crohn's disease due to lack of absorption of oxalate in Crohn's disease. A case of facial swelling and abdominal pain, this is also can come in the GIT or also can come in the autoimmune system. So you are a senior house officer in ER, and please talk to Miss Nora, a 25-year-old lady who came today complaining of facial swelling and abdominal pain. She was given steroids and feels better. Now she is waiting for you to put the final plan. So our differential diagnosis in such case would be, this could be a mast cell-mediated disease and bradykinin-mediated disease. So this is a case of allergy anyway, but most likely it is if it is a facial swelling only with no skin symptoms, and also related systems are having symptoms due to soft tissue swelling like abdominal pain, this will be a case of bradykinin-mediated, or what we call it angioedema. In this case, we have to differentiate the angioedema from mast cell-mediated allergy, because in mast cell-mediated allergy, there will be urticaria, there will be stridor, like laryngeal edema in severe cases with bronchial asthma, and it is due to exposure to allergen. But in case of bradykinin-mediated allergy, it will be due to C1 esterase inhibitor deficiency, and this is a hereditary disease, and angiotensin converting, or sometimes angiotensin converting enzyme inhibitors intake. As I told you, there will be no skin manifestations or anaphylaxis, and the patient will be having only soft tissue swelling in the form of swelling of his face or abdominal pain, and sometimes laryngeal edema as a part of swelling of the soft tissue. So in this patient, you will find